Good afternoon. We're glad to present you our study entitled Minimally Invasive Colectomy for Complicated Diverticular Disease in the Emergency Setting to know if it's a safe choice. I have nothing to disclose. And as you all know, more than 50% of people age over 60 years old are affected by diverticulosis. If we look at the stats, of 100 patients with diverticulosis, 20 will become symptomatic in their lifetimes. 5 will present with complicated diverticular disease, and 2 will require emergency surgery. Although the use of laparoscopic surgery is now well accepted in the treatment of diverticular disease in the elective setting, concerns still remain, and its use in the emergency setting is still controversial because of concern about its safety. Which is why we decided to review and to compare the outcomes of laparoscopic surgery and open surgery for the emergent treatment of complicated diverticular disease. To do so, we conducted a comparative retrospective cohort study that included all patients undergoing emergency surgery for complicated diverticular disease from 2000 to 2011 in a single academic institution in Quebec City. The primary outcomes were 30-day postoperative morbidity and mortality, while the secondary outcomes were time to resume diet, length of hospital stay, and rate of permanent stomas. After reviewing all the files that were available, 57 patients were excluded. 12 of them had diagnostic laparoscopy without any form of resection, 31 had non-complicated diverticulitis, and 14 had other diagnoses at surgery. That left us with 125 patients who met the criteria, and 39 of them had laparoscopic surgery, while 86 had open surgery. If we look at the results, as far as demographics, patients were similar in terms of age, BMI, ASA score, and Apache score. And what is surprising is that there was a trend with a higher proportion of patients in the laparoscopic surgery group with previous abdominal surgery. The InShape classification was established perioperatively, and you can see that there were more patients in the open surgery group with InShape disease. At surgery, there was a majority in both groups of patients with colonic resection and primary anastomosis, especially in the laparoscopic surgery group, where close to 85% of patients had primary anastomosis without any form of diversion. And of course, there was more Hartmann procedure in the open surgery group. With only 2 patients requiring conversion to open surgery, our conversion rate was pretty low and comparable to the results obtained in elective studies. Laparoscopic surgery was associated with longer operating time by around 32 minutes, but was also associated with a decreased estimated blood loss, and the intraoperative complications were similar in both groups. As for the primary outcomes, the 30-day overall morbidity rate was 2 times lower in the laparoscopic surgery group, and if you remember, we had a high rate of primary anastomosis, but only 2 patients in this group had anastomotic leak in the postoperative period. You can also see the expected difference between superficial surgical site infection. And it's important to notice that there was no mortality in the laparoscopic surgery group. As for the secondary outcomes, laparoscopic surgery was also associated with a better recovery and faster recovery. As you can see, there was a decreased number of prolonged ileus, and also decreased time to resume diet and decreased length of stay by 3 days. And finally, at longest follow-up, there was a trend with more permanent stomas in the open surgery group, and also this group was associated with a 25% rate of clinical ventral hernia compared to none in the laparoscopic surgery group. So we do acknowledge that because of its retrospective design, our study comes with an inherent and important selection bias. Although it remains the largest comparative series offering a comprehensive and detailed assessment of laparoscopic surgery compared to open surgery. And it proved laparoscopic surgery to have a significantly lower short and long-term morbidity, as well as a significantly faster recovery in the setting of a diverticular disease that is complicated in the emergency setting. There was also a low conversion rate that we explained by the vast laparoscopic experience in the field of colorectal of the group. And in conclusion, laparoscopic surgery is a feasible and safe option for the treatment of complicated diverticular disease during emergent hospital admission, in our opinion. It seems to appear as to be the approach of choice in the hands of experienced laparoscopic surgeons, but the final decision still has to be individualized to the patient's conditions and the surgeon's expertise. Thank you.
That's a great presentation and certainly a large, relatively large series of emergency colectomies, and I think the largest for a single indication, certainly that I'm aware of. But
it's the largest that is comparative.
So, similar question for you, selection criteria by surgeon. Were the same surgeons doing the open and laparoscopic cases, and how were you deciding? Because it looks from your numbers, not that they're not great results, but it looks as if it's skewed a little that the tougher, sicker patients were in the open group.
And that's a very good, valid point, and I agree with you. There were 11 surgeons who took part in the study, and 6 of them did both open and laparoscopic surgery. And 5 of those were at subspecialty in colorectal and or minimally invasive surgery. And we agree there is a selection bias, and unfortunately there was no data that was available to know what influenced the choice of the surgeon to prefer laparoscopic surgery over open surgery and vice versa. But there was a difference in the INCHE classification, but we like to believe that there is more than the INCHE classification, because INCHE classification is great to establish the loco-regional disease extent, but it doesn't take into account the stability of the patient, the age, the comorbidities, as well as the quality of the tissues. And if we look at our result, patients were kind of similar in terms of ASA score and Apache score. So we like to believe that there's more than a selection bias that can explain our results.
So it might be interesting to do a secondary analysis excluding the patients that were open by the laparoscopic surgeons, because presumably they thought those weren't appropriate cases for laparoscopy, and it might give you a better comparison. Nevertheless, very interesting. One other question, if there's nobody at the podium from me, is your extraction site. What extraction sites did you use from these? Because 0 is lower than you would see in most even laparoscopic series for a hernia, right?
Yeah, exactly. It was at longest follow-up, which was a year, and most surgeons used a left lower quadrant incision. Some used a phanestoid, but the preferred one was the left lower.
Just to get sort of a general picture of your patient population and practices, do you use CAT scan drainage very often in diverticular?
Yeah, most patients, if not all, I think like there was 3 patients who only had ultrasound, but the majority of the patients had CT scan, CAT scan before being seen by the attending surgeon.
So we found exactly the same thing with our hernia rate, less than 1% in the left lower quadrant.
Yeah,
so,
that's
so it fits.
Thank you.
Thank you very much.